today's upper endoscopy session. Again, this is hosted by iEcho for the Gastro Foundation in association with Project Echo from the University of New Mexico. And this is a regular Wednesday session, and this week it is indeed upper GI. We're very privileged today to have Galya Chinnery, who's the head of upper GI at UCT, and she's going to talk to us about esophageal diverticuli. I'm not sure if she's focusing more on the diagnosis or on the treatment, but I'm sure we'll find out. So Galya, over to you.
Thank you, Prof. Let me just share my screen. Right. Won't you confirm that that's showing, please?
Yeah, it is. It's good.
Great, thank you. So firstly, a small apology. My colleague Matt Screeber's on leave today, so the manometry aspect I won't go too deeply into. We'll leave that for another day. What I thought we should do is I've got 3 different patients that I'm going to take you through various aspects of the management of the diverticuli. And hopefully at the end, we kind of come to a conclusion as to how to manage these patients. So patient 1 is a 62-year-old gentleman, and his main complaint for the last few years was progressive dysphagia, chest pain, and volume reflux. And the complaint is that there is much regurgitation frequently after most meals. He has episodic severe chest pain that he curls up in a ball, and he's been treated for many years on a PPI, and he says that doesn't do very much for him. And the most relevant thing, medically speaking, was that he was admitted a few months ago for treatment of an aspiration pneumonia. No comorbidities, and he looks pretty good. So let's start off with the scope. A couple of things to watch when you're doing the scope. I think what I've, once you go down, you see the diverticulum come back and start again. There are a few things you might miss here. I think if you're a novice endoscopist, you might miss that this is a bit tortuous. It is a bit dilated. And as soon as you see so much saliva, there's something going on. Now, when you get to the distal esophagus, it's quite clear what the problem is. To the left of your screen and to the left of the patient, a huge diverticulum. Do try and suck out whatever you can. I think it's pretty important with that first endoscopic view to get a good look at that mucosa. You can get ulcerations, you can get dysplasia. A word of caution, of course, when you biopsy that. If you are genuinely dealing with an epiphrenic, that is a pseudo-diverticulum, so it's just mucosa. So be careful of how deep you take your bites. Then get through your OG junction. You do need to know where your Z line is in reference to the neck of your esophagus. Your diverticulum, apologies. Once you're through, of course, you should retroflex. We'll just move on. You just have to trust me there wasn't a hernia there, but always check for a hernia as well. So that's your first initial meeting with that diverticulum. Let me show you the swallow. I'm going to let it run a few loops, and then you can just take note of what you would think is important to mention here. And then I'd like to take you through it step by step, how I would look at it from a surgical point of view. It's quite clear this is a distal epiphrenic diverticulum, fits in with a definition of sitting approximately 10 centimeters in the distal 10 centimeters. But let's slow that down. So we'll look at a few things. So for me, the first thing is do look at the proximal esophagus. I know the diverticulum is kind of in your face and you can't miss it, but you need to find out why it's there. So look at your esophagus. To me, as I mentioned on the scope, looked a bit dilated. Perhaps a little bit more tortuous was the impression on scope, but here it's fairly straight. But you can see clearly there is an element of dilatation. Now, how do I say that? Well, remember, you've got that thoracic vertebral body in the background that's always there. It's always about 3.5 centimeters. And simply put, your esophageal diameter shouldn't be more than half of that. So you can see here clearly it's bordering on the 3/4 size of your vertebral body. So that's a bit enlarged, dilated, sorry. Next thing to look at, I'm not sure if that projects too well, but there are some faint tertiary contractions of that distal esophagus. And for me, whenever you see tertiary contractions, there has to be an element of some form of esophageal dysmotility. So that's something to bear in mind, which would fit in with why this jolly diverticulum is there in the first place. You must make sort of an assessment of the size of the diverticulum, as size is relevant for how you're going to tackle this later. So this is quite a big one, and I would estimate it about 5-6 centimeters at least. Next thing to take a look at is the diameter of the neck of the diverticulum. Now that's relevant for a couple of reasons. The more narrow it is, the easier it is to get your stapler over, but the more stasis and pain they have. The wider necked ones are trickier to manage with a stapler, but they do empty a bit better. To me, and this is anecdotally, I find that the distal divertics that sit on the patient's right tend to be broader necked. But I'm not sure if that's actually, Prof can perhaps also throw in his opinion later, but I do think that's what we've seen. And the narrower necked ones with a bigger actual body of the diverticulum seem to sit on the patient's left. Other thing to look at, please remember, you need to check where the neck of your diverticulum is in relation to your OG junction. Can be a bit difficult to find. It's usually easier when you're coming back, as there are some folds there due to that positional change with the funny anatomy there. Then the diameter or the length of your neck of your diverticulum, important again. That's something you will appreciate surgically. The longer necks are a little bit easier to staple across, but not necessarily better for the patient. Then, of course, always make a note whether there is much food remnant within your actual diverticulum. Fluid is easy to get out, but if it's full of old food, that does hamper the maneuverability of your diverticulum on the day of surgery. So that might be something you want to sort out before you tackle it, specifically if you're going for it laparoscopically or thoracoscopically. So in conclusion, if you are reporting back on the swallow, these are kind of the things that we've now picked out. So there's dilatation, tertiary contractions. Yes, there's good flow across the OG junction. And there is a supradiaphragmatic position of this diverticulum. It's about 5-6 centimeters in diameter. It has approximately a 2 centimeter wide neck, but it's a short neck. And then you've got confirmation clearly of air fluid level within that diverticulum with some food residues. And then importantly, the neck looks like it's about 3-4 centimeters from your Z line or your OG junction. So all of that from your swallow. So let's talk a little bit about the theory, not too much detail, just so that you have the background. Just do recall that it is very rare. You will come across some as you do your scope lists for sure. Fortunately, the vast majority are asymptomatic. Less than 10% will actually come with complications. From our point of view, the biggest complaint from the patient's point is always regurgitation, volume reflux. 1 or 2 patients, quite severe chest pain, but the regurgitation followed by dysphagia. And on occasion, we've had patients coming through to us via the pulmonology team, where they've presented first with an aspiration. But by far, the commonest is regurgitation, volume regurg. More rarer things that can happen, bleeding. We haven't really had that, to be honest. We had one rather dramatic perforation with fistulization through into the pericardium, which presented as an acute tamponade. So that was interesting. So it can happen, but it's not something that's frequent. And as I mentioned to you, do suck out the fluid of the bottom of your diverticulum, just so that you can see whether there's anything looking a little bit unusual that you might want to take a biopsy of to exclude dysplasia, but don't take a chunky, big, deep bite, rather a little bit of a nibble. Epiphrenic diverticuli in as a cause, it's a dysmotility for the majority of cases. And of those presenting with a dysmotility, 60% of these patients will actually have achalasia in the background. So absolutely mandatory is a high resolution esophageal manometry. As I said previously, usually presenting within 10 centimeters from the OG junction. They do tend to sit more on the patient's right, but if they're on the left, they seem to get bigger more frequently, and this is the area that's more, this is the side that is more likely to perforate potentially. Now, the pathophysiology, we know it's a pulsion problem. It's due to an increased high intraluminal pressure from an outflow obstruction, and then resultant hypercontractility above that, which leads to this formation of the divertic. As I said, it's a motility disorder of the esophagus in the majority, and achalasia is the primary culprit. So this patient that we just talked about clearly needs to go to Dr. Scriber or somebody else for a higher resolution manometry. I'm going to show you just one selected swallow from this patient's 10 standard swallows. 4 of these swallows were exactly looking like this, and the 6 remaining swallows were normal. So I'm not sure if you can read down there, I don't think so. But the DCI, the DCI was particularly high, sitting at 46,000. So remember that the DCI is the distal contractile integral and is there to as an assessment of the strength or the vigor of the esophageal contractions. Now, you don't need the value there to see that this is an incredibly high pressure contraction with sustained over time that's occurring in this patient. If you have, so we've got your DCI was over 46, as I said, and the IRP was pretty normal. And the manometric diagnosis for a hypercontractile esophagus is defined by at least 20% of swallows having a DCI of over 8,000 with a normal IRP. So our patient here with 4 of these swallows easily makes that criteria. You must remember that dysphagia or non-cardiac chest pain must accompany these manometric findings for this diagnosis, and our patient did have that. So all fits in as regards the diagnosis of a hypercontractile esophagus. Quick, very simple picture. I do think if you have a traction diverticulum, it is a little bit stiffer and a bit more puckered and not so big and smooth and round. But I do think you can't be 100% sure once you diagnose a diverticulum. I would always consider, even though pulsion is up there on my diagnosis list, I would always consider adding a CT scan to my investigations before managing this patient. You have, in our country, I think TB is the big cause of traction diverticuli distally, and in the mid-esophageal region. And of course, the older the patient, you start being concerned about malignancies. What you see here is a nice smooth wall of the diverticulum. I've just shown you a single image, not much else to be seen, and we're quite happy that this is not a traction. Just an AP view, similar. So the next question for me is then, well, if all good and well, we've diagnosed it, should we be treating them all? Now, this is quite an old study that I've mentioned here. It's about from 1993, but it's quoted repeatedly. And they proved that even in asymptomatic patients with an epiphrenic divertic, aspiration was demonstrated in 45%. So for this reason, some authors would advocate surgery in all patients with a thoracic epiphrenic diverticuli. Let's think about that first, but that's some opinion. Let's quickly look at our second patient. So this is a 71-year-old gentleman referred to us from pulmonology, fit before this admission. And he was admitted with quite a significant lung abscess and a large empyema, which you can see there on the CT on your right. And this actually required thoracoscopic drainage. And he was pretty unwell. During the CT scan, they clearly made note of a distal esophageal dilatation, and then he went further and had, I'm going to show you just selected images now, and had a barium swallow. I hope this projects. But again, what you can clearly see, as the esophagus fills up, there's dilatation. In this case, it's a bit more complicated. We have a single large left-sided diverticulum with quite a broad neck, very short neck. And then what we initially thought was a potential hiatus hernia, in fact, turned out to be a second diverticulum. His manometry, not hypercontractile, not achalasia, but a clear fragmented swallow very frequently, and he made the cutoff for a diagnosis of IEM, ineffective esophageal motility. Let's talk about treatment options overall. And I think I'm going to not quite agree that we should be operating absolutely everybody, as the previous paper suggested. I think if they're very small and the patient is asymptomatic, you can opt for a conservative management quite safely. The argument to take it further is, of course, the risk of future perforation, and that's size dependent. And of course, the risk in theory due to dysplastic change to that chronic irritation of the diverticular mucosa. Alternatively, if you've got a small diverticulum and you want to treat it, you don't necessarily have to resect it, of course. You can offer just a myotomy. And this is how you should approach it. The idea of this is a small divertic. You're going to leave it behind. All you're trying to do is, in theory, open up the neck such that you have a much wider neck. And the way to do that is to do the myotomy at that point where the diverticulum is protruding. So you're essentially creating a very broad-based diverticulum, which hopefully is much less symptomatic. So that's fairly easy to do. You do have to be a little bit careful when you approach the neck of the diverticulum, but that's quite nice to do laparoscopically from the bottom, from the abdominal side, so laparoscopically. This is a retrospective study from the Mayo Clinic, and you'll see here the number is 94 patients. Now, it doesn't sound like much, but if you think it took them almost 28 years to collect this retrospective cohort of patients, it just gives us an appreciation of how rarely these do actually occur. As it was almost over 30 years, the vast majority of the patients presented earlier and obviously had their surgery done open. But as time has changed, the last 10 patients were done via minimally invasive surgery. So that's fair, that makes sense. What I wanted to show you, though, is that. It doesn't matter how you do it, it doesn't matter who's doing it. This is the Mayo Clinic, they should be fantastic. The complication rate is up there. It's a good quarter of patients will have a problem. And you're sitting about almost at 8% in expert hands of an esophageal leak. So it's not something you should take on as your first case all by yourself. What are your treatment options if your diverticulum is a wee bit larger? I think then, of course, surgery is now indicated because you do need to address both the underlying esophageal dysmotility as well as this stasis in the sac of a diverticulum. You can't just leave that behind. And your options are a combination of removing the diverticulum, adding a myotomy, and then yes or no, adding a fundoplication. What's important, though, not more than what you're doing, but as important is how you get to the diverticulum. If you're approaching it surgically, it depends very much where your diverticular neck is and the size as to what approach you might offer. Just to say the options, you can tackle this from a sort of posterior lateral thoracotomy. You can also go from the front via left thoracoabdominal approach, which is quite nice. It gives you access better, I think, to the lower esophageal sphincter, such that your myotomy can be quite nicely done. You can, of course, also do this laparoscopically via transhiatal approach. That would be my go-to for an easily accessible one. And then, of course, if you've got a bigger one sitting slightly higher up, you'd want to tackle it thoracoscopically. Now, as times have moved forward, the endoscopic options have also come up, and we will discuss just now. But the options are essentially a normal POEM, a salvage POEM, or a diverticular POEM. And I'll take you through those slight variations in a bit. Now, if you have decided you're doing a diverticulectomy and adding a myotomy, the difference to the cardiomyotomy that we showed earlier is that in this case, you take off your diverticulum once you've dissected free all the adhesions and you're at the base of the neck with a stapler for the majority of cases. We would always use a stapler. And then on the alternative side of your esophagus, you would actually then do the myotomy. That's probably safer, and this is what we would be doing as a routine. Now, let's get back to our patient 2. This is the gentleman that had the aspiration pneumonia, the thoracoscopic drainage of a large empyema. A year later, he came to us for his diverticular treatment. And remember that he had those two. So one sitting quite sort of in a standard left lateral position, but then one odd diverticulum sitting anteriorly, sort of right. It looks like a hernia, but was actually a diverticulum. We decided to approach this via left posterior thoracotomy. And the idea was to stay away from, as far as is possible, from the right side of the chest. We thought we would get there better from the left and not from a transhiatal. We thought it would be a bit of a complicated dissection. It was more than complicated. It was horrific. This is a CT scan of the same patient a week after his diverticulectomy ×2. So we had 2 staple lines, one on the lateral side and then one anterior, pretty much at the same level. On the barium swallow, they look that the one is a few centimeters higher up, but it turned out that they were pretty much at the same level of the esophagus. And I think in part that was our problem, in that we had some ischemic injury there for sure. And within a week, we had quite an unhappy gentleman with a clear perforation, fortunately contained on the CT scan. On your right-hand side, there's a clear bit of contrast leaking out. He was quite well, so our treatment was to put down a nasovaginal feeding tube, and we just offered nutrition up until his eyeballs, obviously covered with appropriate antibiotics and chest physio, and he did pretty well. I'm not sure if that shows very nicely, but this is 2 weeks post-op, and he's got his feeding tube down. And what you can see still is a gas-filled collection with a bit of a fluid level. So there's still a leak there, although the contrast wasn't going out very clearly. There's definitely still a leak. And then this is 3 weeks post-op, where you've now got just a small contained little sliver of contrast. And at this point, we actually had opted to take out the tube, and the patient was eating and off antibiotics and very well. Very happy with his result, despite his longer stay, and eating well. So that was good news. Unfortunately, like most diverticuli, they're a gift that keeps on giving. This is the same gentleman a couple of months later, and he represented now with significant dysphagia. So here's a few selected images of his scope. The proximal scope, you can see clearly there's hold up, there's a motility issue with all that saliva. It's quite tortuous. But what I want you to focus on is actually the distal esophagus. That's the distal esophagus. And what you hopefully can appreciate here, there's some white hard tissue here. This is actually scarring from healing where the perforation was. This is the little stump of the one diverticulum that was left. Can't quite see where the other one is, but this is the problem. Can you appreciate there's a slight little fold there? This almost looks like a dead end, but there's a bit of a fold there. And if you go through that fold, there's a nice normal esophagogastric junction underneath that. So what's happened now, the reason for his dysphagia, in my opinion, is that he's got this kind of sump effect with a bit of distortion. And as he's got such poor contractility above, he's unable to get his his oral intake down himself past that fold. Here, I hope you can see, is a swallow, kind of demonstrating what I'm trying to explain here, what I think is the problem. Diaphragm here, there's a bit of a sump effect, and if you can see, there's a little band of tissue there, which to me correlates nicely with this fold. I'll just zoom in a bit there, coming down, and there's this band of tissue, which I think is this fold. So you can imagine if you've got very poor proximal forward peristalsis, that's going to struggle to get through. So I think that's the reason for his dysphagia. Yeah, so a bit stuck as to what to do there. We then opted to take him for a laparoscopic exploration, having not been there from the start. Remember, we went through the chest the first time. So we went transhiatally. It was so super stuck. But I think the end result you can see is a bit straighter and without that fold. And initially he did pretty well and reported an improvement in his swallowing experience. So we kind of all we did really was a OG junction straightening, if I can put it that way. And to me, the problem was that that scarring had actually stuck itself down onto the diaphragm. So it was pulling itself lateral, which is why the sump effect was there. So let's look at the surgical considerations. The CT scan, as I mentioned, yes, you want to exclude a traction diverticulum. But the other thing that makes your life quite tricky as a surgeon when you're trying to resect these diverticuli is the adhesions or the sac or whatever you want to call it that sits around them. Sometimes you see it on CT, other times you don't, but it's nice to know about it before. In that if there's some thick bands there, it's a risk for conversion, and it's something you and the anesthetist should have prepared for. The bigger the diverticulum, the more difficult it is to get to the top of it from the bottom. So that's something else we'll consider shortly. Site and size of your diverticulum. I think it's jolly tricky if your diverticulum from the OG junction is more than 5 centimeters away. Then your laparoscopic approach from the bottom is going to be tricky, especially if it's a big one, because then it's not just 5 centimeters to here, then you've got another 5 or whatever it is to get to the top where all the adhesions are. And the angulation from a transhiatal approach from the bottom is not going to allow a 10 centimeter dissection very well. So if your diverticulum is far away, probably best to go via the chest. The other thing is, as I said, the size. If it's a large one, and the sort of the guidelines are if it's over 6 centimeters, again, you should be considering approaching it somehow via the chest. The other thing to consider, I think I mentioned it right in the beginning, is your diverticular neck length and the actual width. So long necks can be quite difficult to appreciate when you're coming from the bottom. So that's one thing. You have to really be on the lookout for them. The wider necks, you may have to fire more than one stapler. And every time you fire more than one stapler, specifically laparoscopically, if you don't get it quite right, there's a crossover of the staple lines, and that may be a potential site for leakage. You can quite clearly see this short little neck on the right-hand side would be beautiful and easy to chomp through with one staple line. So that must take some consideration as well. Then, of course, the food retention I mentioned to you, it makes it so difficult to maneuver. If it's fluid, you can go down with a scope pre-op and just suck it out. But it is definitely worthwhile making sure that there's not actual solid food in there before you start maneuvering that laparoscopically or thoracoscopically. So if none of these concerns are present, then I would probably opt for a laparoscopic transhiatal diverticulum resection plus a myotomy. And then if any of these concerning factors are there, you definitely need to consider a thoracic or a left thoracoabdominal incision. Now, let's quickly talk about endoscopic management options. I think these are, yeah, they definitely, a POEM is fairly tricky at the best of times if you're starting off, but when you throw in a diverticulum It makes it even more hair-raising. But let's talk about it in principle. How would you approach it? So a salvage poem, just so that you know the terminology, is basically a normal endoscopic myotomy as you would do for a simple achalasia on the side opposite to your diverticulum. And you just perform it longitudinally as you would normally do. Of course, you have to go as per normal across the OG junction in its entirety. But what you're trying to do is essentially open up the OG junction, same like you would be in achalasia, such that the actual drainage is better. So perhaps just look at the picture on your right. This is not obviously my image. This is from an article, but this is pre-myotomy. So the myotomy was done down the side, not near the diverticulum at all. It's been left alone, but you clearly have an improved drainage. And you can see that by the diameter decreasing and your OG junction flow much improving. So hopefully that would be enough to improve your patient's symptomatology. Just for the endoscopic view, this is one that was lying on the right from this article, and there's the true lumen. If you see a big lumen, it's always the wrong place, so proceed with caution. The true lumen is always squished shut. So that's a salvage poem. It's basically a normal poem, but on the opposite side to your diverticulum, and you leave the diverticulum alone. Let's add a third patient. This is a lady that is also giving me some gray hairs. She is 72. She's got a multitude of comorbidities. She's exceptionally symptomatic. Volume reflux is her big thing, and dysphagia, of course, and she's got a significant loss of weight to the point that she is now with a peg. Now you can see from, I'm just going to let this run a few times, but what you can see there is a little bit more dramatic than the last two videos that I've shown you. There is a large left-sided distal epiphrenic diverticulum, and again a second one, but not quite as big as our previous patient, sitting just below that. And then you've got quite some dilatation and tortuosity clearly visible of the esophagus. Now you can see that, well, I hope you can see that the diverticular neck was quite broad, meaning that when you go down with the scope, it was quite dramatic that you fall into the diverticulum, and you can imagine whatever she eats does exactly the same. And similarly, in reverse, whenever she lies down, whatever's puddled in that diverticulum, whoop, comes straight up. So she has a tremendous amount of volume reflux, and very little is actually passing beyond that and going down. So she, because of her comorbidities, this is a lady I did not fancy at all offering anything particularly invasive. Not that I don't think a poem is invasive, but I do think you avoid the cavities. And we offered her a salvage poem. I can tell you this was not an enjoyable experience. It was tricky, but she did quite well from that point of view. And here is her post-op swallow. Now, let me explain it before you all wonder what on earth is going on here. Unfortunately, first of all, she had her day one post-op swallow, not on day one, but about an hour or two after her actual operation. Once she was awake, that was a miscommunication with radiology, so they did her immediately. That's why you see so much surgical emphysema, and you see a huge, big amount of CO2 still within the abdomen. So one good thing is we know we've traversed into the abdominal cavity across the OG junction. But what you see, which is the most concerning thing, is that although here's the clips, I don't know if you can see the clips there, no leak, thank goodness, no leak elsewhere, still a huge dominating flow of contrast straight into the diverticulum. And despite the myotomy, almost no flow going distally. So I did very little good for her with this salvage poem at all. I didn't do her any favors. So what is a diverticular poem, on the other hand? Now that's a bit different, and there's two parts to it, which I hope this diagram sort of explains. What you do is you come down on and perform a normal myotomy as you would with a poem, but then you come back and you perform a almost second aspect where you divide that bridge of the diverticulum. And as such, you're not removing anything, but you are opening up by taking that bridge down. You're opening that, whatever, 2-3 centimeter lumen into a much larger lumen, such that whatever swallows down goes whoop in and out and doesn't sit and cause stasis there. So you basically, like a Zenker's diverticulum, you're dividing that common bridge and just leaving the diverticulum behind. And I think in retrospect, this is probably what I should have done for this lady, but I don't think at that time, which is a few years ago, I would not have endoscopically had the skills to do that. I would have been quite scared. I also don't know how you would tackle that second diverticulum slightly lower down. So not quite sure. But if it had been a single large one, I think that would have been better if you were trying to avoid surgery for her. This is just to show you what it looks like. I hope you can appreciate. Obviously, this is from the article. Very nice pictures. There's as you go down with the scope, there's that bridge that you're looking at, and you actually start your myotomy pretty close to that, as per usual. Submucosal injection, go down, make your tunnel. And then you come back once you've divided the muscle and you find that common bridge between the two. And that is then the second step where you cut that bridge and completely divide it open, such that you've got this huge neck, so to speak, a common channel rather than these two separate channels. And then, of course, you close up with your clips. So we're back to patient 1. Remember, this was the 60-something fit gentleman with aspiration pneumonia. There is his swallow again. And I now ask you, what should I be doing, knowing that there are some issues with treating these things? I've got in my armament now a salvage poem, a diverticular poem, or a diverticulectomy and myotomy. And I can attack that from an open left thoracoabdominal approach, laparoscopically, or left posterior thoracotomy. So we haven't done him yet. I think that in view of it's about 3 centimeters to his OG junction, we are going to try, we're going to try transhiatally from the bottom. This is a diverticulum of such a size that I do think it's quite worthwhile to get rid of it if possible. But in view of the actual diameter of the diverticulum, though, the top aspect here might be difficult to get to. So we do have to chat to the patient that we might have to convert or approach this at some point through the chest as well. So for the moment, I'm going to try and do this via a transhiatal approach. So that's kind of my story, my take on it. I think the diverticuli, they're not always small. We never see small ones like that, like they do where you do well with just a salvage diverticulum, salvage poem. So for our patients, they're usually very large. And as I said, usually, funnily enough, on the left side, the large ones. So we would really offer them surgery for the most part. I know this is an endoscopic talk, but yeah, the big ones we see more frequently. Not sure your experiences, Prof. Perhaps you've got a few words.
Hi. Sorry, I'm sort of just. Are you finished, Galya?
Yes, thank you.
Have you got some take-home messages, perhaps?
Well, I thought I was giving them, but my take-home messages
No,
are
no.
that as an investigation, I think the swallow is underappreciated. You kind of just look at it, see there's a diverticulum and move on. But the swallow helps you decide how to approach this. It gives you a very nice idea of the functional it gives you a better idea of or appreciation of the patient's functional experience of swallowing, I think, much better than a scope does. So I'm a big fan of a swallow, but look at it properly. Don't just, you need to measure it, you need to plan it. This is a disaster when it goes wrong. And as you can see, I've got 2 patients here that haven't done particularly well. So that's my first thing. Don't underestimate the swallow. Look at it properly. Then always do a CT, even if it's just one You just need that confirmation that there's nothing else brewing in the background. Although the traction diverticulum do for the most part look differently, but I do think it's an essential thing. If you have manometry available, it must be part of your investigations. I do think you have to appreciate there's two things going on here. You are dealing with the consequence of a motility disorder for whatever reason. So you can't just lob out the diverticulum and leave the lower esophageal sphincter to carry on. You will just blow your suture line. So the myotomy, I think, is definitely part of the deal. Yeah, I think that's kind of my thing. The endoscopic treatment options I would reserve for the smaller diverticuli, or for what I was trying to do with the second patient, where the patient is not fit for an open procedure. But that said and done, for the very large ones, I've got no real experience doing a deep home. So I'm not sure how well that would work for a diameter of 5-6 centimeters. I would imagine that might be quite tricky. I think the endoscopic options should be possibly more for the smaller diverticuli. That's definitely what I would be doing in the future. Thank you.
Can I ask you a question about the first patient you presented who complicated with the two diverticulum? Did you do a myotomy on him? Or
Yes.
were you convinced you did?
Yes. Yeah, but because and this is my concern from approaching from the chest side. Yeah, I'm just not going to buy that you do a beautiful distal myotomy very well from the chest. I know the thorax surgeons will tell us otherwise, but I do think you appreciate the distal myotomy better from the bottom. So what I can't answer you, Prof, is did we do a very good distal myotomy? Was it adequate distally? I don't know. It was really unpleasant. What is now the problem, when you get through that little fold, it's beautifully open. So it's not like there's any form of obstruction. I think this is more a physical issue, that there's a distortion of the anatomy. And because there's no peristalsis from above, it's just not overcoming that little distortion. So yeah, tricky one. Yeah, I don't know where we're going to go with them, to be honest.
Yes. Again, sort of the original description was a guy called he was a thoracic surgeon, Ellis, and he was the chap who popularized doing the myotomy through the thorax, originally not to do with diverticuli. Again, that stuck with a lot of thoracic surgeons. But I agree with you that I think if you're doing a myotomy from the outside of the esophagus, then the best place to do it is looking at it from front on, from below.
Yeah.
So again, sort of, it seems to me that sort of a combined approach is, even if it, sort of posterior thoracotomy to get the diverticulum and your myotomy from below thoracoscopically. That sounds like a reasonable approach. But one other would still be to do the poems and just the thorax. To do it that way. To do your salvage, well, not salvage poems,
So
because you're
to do your diverticulectomy and then do a salvage poem
well, to do the
on the other
salvage
side.
poem, I think you
Yeah.
must do it before the diverticulectomy or at the same
Yeah.
time.
Yeah. No, that would also work. Yes, that's true. Yeah.
Yes.
And you'd avoid going into both cavities. That's true.
Yes, yes.
Yeah.
You just have and again, sort of, I don't know what your experience is thoracoscopically, but the other aspect that I think is really essential is that anesthesia, if you are going into both cavities, it's absolutely essential that you have the single lung ventilation. And that might have been, I don't know if that was very tricky on your first patient because he had that empyema on the right. I couldn't
Yeah.
imagine
No,
his right.
it was not fun. I think
No.
for the thoracoscopic approach, as for our esophagectomies, you don't actually need to collapse the lung. You can actually just do that with insufflation, enough to be able to mobilize that. So I don't think you need to collapse the lung all the time.
Mhm.
But yeah, I hear you and I would agree.
Yeah. I think And sorry, you didn't. I mean, there are some very typical traction. Um, you alluded to it in the middle of the esophagus related to TB scarring, and they're traditionally usually quite small and multiple.
Mm,
Often,
mm.
they're not
And
usually of the
they're
size.
puckered. They've got a
Yes,
sort of a pulled, puckered appearance, not this beautiful round inside a balloon look. Mm,
yes. But
yeah.
the other one you didn't cover today, perhaps it's a topic for, is obviously the Zenkers.
Mm.
Because you that obviously I think qualifies as for most people as an esophageal diverticulum, but maybe
Yeah,
it's
I think we've kind of abandoned, not abandoned is perhaps the wrong word. It's an area that's been taken over by the ENTs with their stapling. Um, so we don't do many. I can't remember. It's been a good 10 years since I last did a Zenkas, I must be honest. So for us, that is kind of,
yes.
yeah, I don't
I
do them
think
anymore.
the one thing I was also taken with the ENT with the stapled version, and
Mm,
but I think there's no doubt that particularly in the one thing about that is you really need to straighten the neck. And in old people with Zenkers, straightening
mm,
the neck is a bit
mm,
tricky. And I think
mm,
there are quite a few, the endoscopists are definitely striking back in terms of taking on certainly these older patients. And
mm,
again, sort of, it's exactly the same as you showed it there. If you can see the dual lumen,
mm.
and so one of the other things maybe that is important for the viewers is that if you come across these unexpectedly, the Zenkers particularly can be something that that you've had difficulty with intubation. So what's your approach to the patient, especially if you're an experienced endoscopist, in whom it's really, you seem to get lost every time you try to intubate the esophagus? Do you have any tricks for intubating the esophagus, not
You
just
need to
because the
sedate.
patient's restless?
Yeah, you need to sedate properly. Because remember the neck of that Zenkus is very close to your cricopharyngeus, and if you've got a patient that you're shoving your scope down, you can perforate. So if you're struggling, sedate your patient properly. Then if you're still struggling, get yourself a jag wire, which is a soft tipped wire, and you feed it down. And if it goes well, you follow with your scope. I never use a metal wire because again, that can perforate if you're going down the wrong lumen. But if I like to follow a soft jag wire, that works for me the best. If you have fluoroscopic opportunities, well, fantastic, and you can do that even nicer with a jag wire. But that works the best for me. Sedation and a soft tip jag wire.
Yes. I think also if you've got someone when you're actually if they come with dysphagia, if they localize it to the neck, I think it should be a warning sign that if you have a difficult intubation, you should think of the methods that you use. And I like the one of using a guide wire that you can be 99% sure is down the true lumen,
Mm,
because otherwise it would come back up and come back at you
yeah.
as a fairly good way. And but I think there's the other thing with these epiphrenic diverticula, and I know of two cases where they've been perforated at ERCP. And again,
Mm,
yeah, and I
mm,
think that's also for those who are doing ERCP, if you have any resistance at the OG junction, if it doesn't go as smoothly as you think, because it can be a complete and total disaster, and it was in these two patients.
mm,
They got far more than they bargained for. Of course, that's the thing now is that we endoscope these patients before the barium. When I first started, the barium really was the first investigation for dysphagia that
mm,
you would do. So again, I like your idea of going back to when you need anatomical and physiological definition. You really need to do all the tests to really get a handle on your scenario that you've got in front of you. So
mm.
I like all three, and you can throw a CT scan in for good
For good
measure.
measure. Yeah.
Sounds very good, but I think it for I think you've got some very good to the audience. I don't see anything in the chat. I think you've stunned them with difficult surgical problems, and I think for the jobbing endoscopist, just watch when anybody's got dysphagia or atypical symptoms, that there isn't a diverticulum lurking. And if you have difficulties, do a barium study. So thank you, Galya. Thank you for
Thanks,
coping
Prof.
with that. And thank you for putting us in the picture. It was some beautifully illustrated cases. And it's a real world out there. These things are never quite as straightforward. I think you shouldn't be too unproud that you got the patient through and that
No, they're not like the textbook, that's for sure.
no, sure. They don't behave
No.
properly, that's for sure.
Yeah.
So thanks again. And on behalf of, remember this is recorded for those of you who want to see it again. I think next week is pediatrics. And I'd just like to thank Galya and also Cheryl for putting things together. And I hope you enjoyed this sort of trip into rarities, but rarities are important to know about in your endoscopic practice. Thank you very much.
Thank you. Bye-bye.
Bye.